Talk that I'm just going to do now on inhaler techniques and adherence. I've used 3 main papers as the source of my information, and the reason, and they all essentially say the same thing. So the papers that I'm using this morning is the Inhaler Competence in Asthma, Common Errors, Barriers to Use and Recommended Solutions. It's a review paper from the Inhaler Era Steering Committee. That's that official title from the UK. It was published 2 years ago. The next one I'm going to be using is one from Jeff's friend, Professor van der Molen in the he's based in Holland. Yeah. And that was published earlier this year, a couple of months ago. And that's called Towards Tailored and Targeted Adherence Assessment to Optimise Asthma Management. And the third one I'm using is Peter Gibson's Self-Management Education from the Cochrane database. So, as I said, I've done a lot of having a look at this concept that we call adherence. And I know that it can sound really, really boring, but when we're looking at asthma management, at respiratory management, and we're looking at inhalers, it's one of those things which is absolutely vital to helping your patient manage their disease better. And the responsibility for adherence and teaching people how to use their inhalers does not sit on the nurse, it sits on everybody in the practice who's involved with patient care. And where's my button? Here we go. So why do we need to check it? Well, we know that people who've got good inhaler techniques and good compliance have better control of their asthma. I mean, I don't know if any of you have, I used to, when I used to run the respiratory clinics, I'd say to patients, especially those men, I'll give you the 30-day challenge. You know, if you use this spacer with your inhaler for 30 days, morning and night, and you don't see an improvement, then throw your spacer away. Never had anyone throw their spacer away. Your asthma control will remain suboptimal unless the reasons for the lack of control are identified, assessed and eliminated. And that comes back to us as health professionals. You know, we need to be assessing our patients' health literacy. The example we used earlier of Stephen, very poorly health literate, he'd gotten over the course of a previous pulmonary rehab program, he had understood finally that he needed to use one of his inhalers every day, and once he was using that properly, he continued to, but the rest of his inhalers sort of fell by the wayside. And we need to check their adherence frequently as well. So it encompasses multiple dimensions. So one part of it is the intensity and the timing of use. So that's compliance. So those of us who've got access to databases which tell us, you know, we can have a look up, patients picking up Ventolin on a weekly basis. They haven't picked up their tiotropium for 6 months. You know, we get an idea immediately of what's actually happening with that patient. It's a lot easier with databases now rather than having to phone the pharmacist to say, you know, when did this patient last pick up their XYZ. You know, continuous use, which we call persistence. And one of the things I do in my practice is, instead of saying to the patient, you know, how often do you use your inhaler? Well, I will ask that question, but I'll also ask the converse. How many times a week do you forget to take your inhaler? And you often find you get better information from your patient by asking them that, because you're acknowledging that we don't all take medications as we should take it, and that's a common thing that happens. And then the third part of it is correct technique. So, World Health Organization and these papers I've talked about earlier all talk about different types of non-adherence. So we have our erratic non-adherence, just forgetfulness. That's a person who just simply forgets to take it for whatever reason. And you know, there's a variety of reasons according to the people that you see in front of you. We have intelligent non-adherence. So that lady that we had earlier in our case study, Penny, intelligent non-adherence. She had chosen not to use prescribed treatment. She had a whole range of reasons why she chose not to use it. And in fact, actually, she didn't take any medications for her depression as a result of rationalising that her depression medication was impacting on her cholesterol. So she didn't do it just with inhalers, she did it with all the medications that she had been prescribed. And then we have unwitting non-adherence. So that's someone like our Stephen patient who, you know, didn't understand that he needed to take a particular medication at a particular time. So each of these patients, however, requires a different approach to manage them. And it can sound like, you know, a lot of one of those difficult things to manage. But actually, just practicing the techniques, improving the questions that you're asking, working out what's the likelihood of what's happening with this person sitting in front of you, what type of adherence or non-adherence have they got, how are they managing their asthma, and all of those things come up to what they call an personalised asthma adherent management. And it can be enhanced by closer intelligent monitoring. And the intelligent side of the monitoring isn't just the smart hailers, but it comes back to us as health professionals looking at the person in front of us and trying to figure out what's going on with that patient as well. I think you're going to be talking about your robots and things later, briefly?
No, I'll mention robots.
Okay. So in part of the intelligent monitoring, and Heidi was saying that they're involved with a study at the moment, certainly I've been involved with a telehealth project as well. A lot of those strategies of looking at electronic monitoring of patients' adherence is one of the primary factors on it. And it's all around reminding patients to take their medications so that they end up having better self-management techniques. You've got, in Jeff's robot study, they've got a little smart hailer which attaches to the end of their inhaler, and it can download through Wi-Fi, isn't it? It's a Bluetooth connector. And it downloads how many puffs of the medication the patient's taking at different times. Really interesting stuff, but you know, when you saw on the pyramid, very, very top of the pyramid. So what do we find when we're looking at adherence? We find that people either over-report their adherence or they under-report their adherence. And that's where your careful questioning, assigned with, you know, having a look at electronic records. It could be, a family member of mine with asthma, you know, was routinely being prescribed Ventolin, never mind the fact that they actually didn't ever use any Ventolin. Until I finally said to that person one day, can you just tell the GP not to put Ventolin on your prescription because you don't need it, you've got 6 in the cupboard already. So that would have looked electronically as though that person was going through a 1 Ventolin inhaler a month, where in actual fact that wasn't the truth. So questioning of that will sort of elicit those types of things. Your other one is the person who, particularly your busy mums, when did you last take your inhalers? Yesterday, I think. And then when you sort of question it, actually they've forgotten to take them for the past week because they've been in the bottom of the handbag and there's too much stuff in the handbag and they can't be bothered, and you know, you've got all of those different types of things. So how are we looking at it? We're looking at prescriptions. And I actually think that pharmacists have a major role to play here. I have 2 community pharmacists who've contacted me in the past 7 years to say, I am really, really concerned about this patient. They're picking up a Ventolin inhaler every week, and the only reason that they'd picked it up was because that pharmacist had seen that person coming in twice in a month and gotten a bit suspicious about what else was happening, because she'd seen a whole clutch of inhalers in this person's hand, and she'd phoned the GP and the GP had only prescribed it once. So she thought, this patient's, they're medical shopping. They're going around to emergency departments and they're getting prescriptions from here, there and everywhere. And I think that there's a really good connect when you've got a good relationship between your medical practice and your pharmacy, for them to be able to say, hey, there's a flag here, this person's going through lots of meds. Is it worthwhile getting them referred into something, or is it worthwhile talking to them more about their inhalers? And I know that some of the pharmacists around will do that with patients as they see them. In terms of us, I mean, we see in secondary care the people who are being discharged from hospital and they've got a script from hospital, and then they've got a script from their GP, and then they come into clinic and they say to me, can you write a prescription? And I say, well, I'm not a prescriber. And before I'll go and ask one of my docs if they can write a prescription, I'll go back and check, hang on a minute, how much have you got there? Have you got any repeats? So instead of just doing that, and automatically wandering down the corridor and hitting up Jeff for a script. Let's look at self-reporting. So how do our patients report their medication use? Well, you know, I often push them, and when I say to them, how many times a week are you forgetting to take your meds? Oh, no, I always take it. And I say, you don't ever forget it if you're away from home or any of those situations. And sometimes then you'll get the, well, actually, you know, every fortnight I go to blah, blah, and I forget to take it then. We're looking at disease control. So, you know, your asthma control test, your COPD test, you know, nighttime awakenings. I always say to people with asthma, you know, oh, are you waking up in the night at all, in a very offhand sort of fashion? And they go, oh, yeah, I do. All right, tell me more about how you're using your inhaled steroid. Show me how you're using your inhaler. Then, of course, as Jeff's just talked about, we're looking at biomarkers. And this is where also you can get a really good picture of how that person is actually using their treatment by what's happening, you know, objectively, what's happening with their biomarkers. Anyone got any comments on that? Anything this is a very collaborative one. You all do this with patients, so if you've got any fantastic ideas to add, please add them in.
I think that's a really good point made. I think if somebody comes along and they've got an increased nitric oxide level or an increased serum acetyl, and they're suboptimally controlled despite a reasonable dose of inhaled steroid, you say we've got a problem here. You know, there's two potential reasons. One is we're not giving enough inhaled steroid, or two is you're not taking the medication as we have obstructed. Which one do you think is most likely? And put it back in their court, but then let them reflect on that. I think that gets them to engage and reflect on it as well.
And one of the things we do in our team at Middlemore, certainly from a multidisciplinary perspective, is that'll often be when I'll get a letter from one of our SMOs who'll say to me, Nicola's person came into clinic, this is what happened, are you able to go and check on them? You know, able to go, and I'll pop and see the person at home and actually get a really good picture of what's actually happening, come back and report, and it could be that there's this falling down old house that's dusty and damp and all of these things, and this person has this massive allergen load on them, and we'll start working from there again, maybe increasing the amount of steroid that they've got, but also working from a social perspective and sending them off for warm-up and all of those different bits and pieces that need to be done as well. So that's very much a multidisciplinary approach to that all. Having said that, we also use the practice nurses. Okay, so I'm quite happy to be on the phone to the practice nurse and say, you know, what resources have you got at your particular PHO? You know, some PHOs have got masses of resources and they're able to do that sort of thing themselves, and there's some fantastic respiratory nurse specialists out there in the community. Others, you know, it'll be me that'll end up doing it because maybe there's not that resource available. So what's some of the things we can do to encourage adherence? Well, the first thing we can do is simplify their prescriptions. And I mean, it's gotten better with the amount of, when things like Vanier, Symbicort and Serotyne came onto the market, and prospectively we're going to be having some more combination therapies coming through as well. The other thing I think of in terms of simplifying prescriptions, and I've been into enough patients' homes and hauled out enough medications, 2 laundry baskets, as I will literally go through their medications. At times I have a pharmacist who's available to come with me, and home visiting with a pharmacist, if you've never done it before, is an amazing experience. They just, yeah, fantastic. And that also really helps because they can help that person, you know, rationalise their medications, and you get, because you're sitting in the patient's home, you know, you're on their turf, you're the visitor. You know, there's a lot of information that you get from the patient that you wouldn't when they're sitting in your clinic room. Training, and this is something that we can get quite blasé about, but in actual fact, we should be checking some technique every time we have a contact with that patient. And it only takes a minute or 2. But it's really, really important. And it sort of has been brought back to me time and time again when I have patients coming in and sitting in front of me, and I know that I taught them how to use that inhaler. And 3 months later, their technique's not so great. And I know that I taught them properly, but this is reinforcement. And I think it's something that we need to get over ourselves as health professionals. You know, you can't go, oh my goodness, but I taught you. You just say, oh, okay. Or they tell you the story about the nurse that taught them that way to do it. And you know, no, you didn't. So we really do. All of the information we've got out there around adherence says you need to double check techniques, even if they've been on it for years. I like the ones who say, the doctor says that my cat gave me asthma, so they, you know, putting the puffers on the... And we have seen that. We've seen just about everything. And again, consistency is a thing. So in terms of teaching spacer inhaler techniques to patients, I always teach a multiple breath technique. And that's because even though one of my family members uses a single breath technique with their particular inhaler, you know, they're able to do that. But my patients out there, I want them to all learn the same thing. When I was just starting my respiratory journey, at Journal Club one day we were talking about this, and they got all of the health professionals in the room to each go up and show how they taught spacer inhaler technique. And it sat with me because I was pleased it was so consistent. Our doctors and our nurses were all teaching the same thing. What have we got next? So we're going to do a little bit of show and tell. And I've brought a couple of things here. So as you see, that's a metered dose inhaler, but not all metered dose inhalers are made the same. And this is something, when I was talking about consistency before, and this is something that Jeff and I have had discussions about. QVAR's got particularly fine particles, and the information about it talks about it not needing a spacer. But I keep saying to Jeff, when he kept saying, but you don't need, I said, in the issues of consistency with our population group, we need to be teaching people to still use it through a spacer. Because the very fine print also on the bottom of the brochure says, if correct technique is used, then your lung deposition rate is blah, 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 blah. So here's our spacer. Good old spacer. Okay, I've got a couple here today. This is one I confiscated off a patient. Okay, so before I've asked him anything about their inhalers, I actually know what's happening. Any ideas? Not primed properly? What about putting 2 puffs or 3 puffs or 4 puffs or 5 puffs in at a time? Okay, pretty disgusting, hey? And this one, this was one patient. I had shown him, I'd confiscated an inhaler, a spacer that looked like this, and then a month later, when I checked his inhaler technique again, this is what I found. So
I can remember when I first started, and I went to the Asthma Foundation conference, and we had a respiratory nurse that talked about spacers, and she actually said that she doesn't talk about priming because by the time they've used it 2 or 3 times, they've primed it. And I haven't done that. I've talked about priming with them, you know, but that's always in the back of my mind.
Well, we talk about priming. Diana, our respiratory nurse practitioner, she always uses the word washing a spacer. Yeah. We tend to talk about washing the spacer. If I'm giving a spacer to someone in clinic and I'm priming it, and I do have a Ventolin, I will walk out of the clinic room. I don't ever 10 puffs of Ventolin into the spacer in front of a patient because I've seen that reflected back before, you know, from emergency department or wherever. So priming, really, really important. In fact, so these are our 2 spacers which at the moment are funded, okay. I'm being a little bit naughty, but I brought this one along as well. Because I know that some areas are using, I think Bay of Plenty, Hawke's Bay.
No, we were. It's actually changing, Nicola.
Yeah.
So it's that mate, but it's the yellow one that doesn't go apart.
I've got about 4 different colours of them in my office. I bought this in this interest of space saving in my suitcase. But one of the reasons why we actually haven't pursued going down this way is actually around consistency, because this one doesn't need to be primed. And yet we're teaching everybody with these ones that they do need to be primed. And so because we have a really a big population with a low levels of health literacy, we've had some very, we like that spacer, but yeah, really wary about bringing it into our population. So what is a spacer? A spacer is a medicine delivery device, okay? And I have in clinic, I shouldn't say it, I have seen our respiratory physicians use a rolled up piece of paper as a medication delivery device, and I have myself in an emergency situation as well. But what the object is to get the medication from here into your airways. So priming, yeah, very, very important. Now with all the new medications that are coming on the market, so for years we just had this one, okay, the big spaceship, which needs to be replaced after about 9 months. Some people send them off to their local op shop. They're really good for plants, little glass houses, and or in the kids' sand pits. But first, when Van Air came onto the market, different shaped aperture, and that's when these space chambers were funded. They were funded before for private practice and children, but that's when we were first able to get them in the district health boards. So really important though, got not enough hands. So Cuvar's got another different shaped aperture as well. And I have seen people really, they're not thinking when they're prescribing. They go, oh yeah, and they'll prescribe this and they don't realise that the patient's got one of these. And you get your poor old patient who's trying to say, but I've been trying to use it in a spacer, but it just isn't going to fit, you know. So you have to think about what device you're prescribing and what your patient actually has available to them, all right? And I know it sounds obvious, but I've seen it when people haven't thought too hard about that. So let's just briefly do this. So you've got your nice primed spacer, either your 10 puffs of Ventolin or else it's been washed, warm soapy water, a couple of drops of detergent, give it a good wash around, flick the bubbles off, upside down to air dry. Okay, and I can do that in several languages, by the way. And I'm not going to right now. And I can do this in several languages too. So what are we doing? We're shaking it. Always shake it. Saw a paper across my desk 2 weeks ago about the particles inside the canisters and the different sizes that they are, and that this disperses those particles into the right size ones to come out this aperture here. So quite important. Shake it, 1 puff, 5 breaths in and out with your mouth on here. If they're going to repeat it, another 1 and another 5 breaths. I can often tell the people I've taught because they'll be waving their fingers around doing this. Common questions, common reasons for not using your spacer properly. The first thing the patient will say is they're rebreathing their own air and it's dirty. So cut them off at the beginning by explaining that when the valve closes, the air's going to come out the side and they're not rebreathing their own air. And that's actually a really big factor in patients not using their spacer properly. Anyone have any comments on other reasons why they don't like using these? It's too big?
Too big.
Yep, handbags. Some people have said these are too big. So I have a very occasional patient who's really bad, who I will sneak a couple of these that I've got into them, and they are very delighted. I tell them they're not allowed to show anyone it. Often people, when you first give someone a spacer, pull it apart. The number of patients who don't realise that their spacer actually pulls apart, okay? And generally, if this bit comes off, it's usually because it's got a crack on it. So 1 good drop on the floor will do that. These will last about 2 years. You need to warn them that this can get perished, and that if it starts curling or getting perished, it needs to be replaced. Some pharmacies will charge a lot of money for a spacer, so I always tell people where they can get them free. Right, any questions about that? There's a space chamber. I've covered that.
Nicola, can we just emphasise they are single patient use only?
Yeah,
Because I have
absolutely.
seen them washed out in places in previous rugby.
Good point, Sue.
Yes.
And actually, let's just briefly... Yeah, we don't tend to have that so much here because we tend to hand out quite a few of them. Our team was involved with Samoa after the tsunami, and they didn't take spacers along with them as medical supplies, because in Samoa they use Coke bottles, and they didn't want to change the practice in that particular area. So don't mock the Coke bottle either. That's just again saying, think about what you're prescribing, think about what type of spacers they've got, ask the patient if they've got it, and ask them if they need to be renewed. Turbohalers. One more thing before I do that. When you're assessing someone's inhaler technique, you can also assess whether they're able to use the medication. So if that person, I'll do this a lot in pulmonary rehab, you know, they can't depress their the plunger, then you need to whip out some of these. These are free from the reps, okay? Halerades. Look at this. Just fits over the inhaler. I mean, it's like magic. And it makes life so much better for patients who have difficulty pressing or depressing that. As that, by the way, is not limited to age. So don't just think about these for your adult patients. I have a 16-year-old patient who can now take her inhalers herself because she has one of these on her inhalers. They come in 2 sizes and they fit all the inhalers, and you can make them fit, I think you can even make them fit the van ear. Turbohaler. So a turbohaler technique also really important that the patient's taking it properly. And for my purposes, I'm sure that I go through more of these inspiratory flow whistles than anybody else in New Zealand. So these are fantastic, and you should have them in your practices to check your patients' inspiratory flow. The number of times we're in hospital and I've got my little bag and the patient's on a turbohaler, and before the team move on I say, hang on, let me just check that in their technique, and the patient can't make a sound. So we go, aha, there's a problem. They don't have enough to get the medication. And I mean, this is again something that Jeff says to me, they should be able to, 30 litres a minute. And I just say, well, if they can't show us that they can use it, then they need to be on a different medication. It's something that is important. The other thing I do with one patient, once I've given them one of these and checked their technique, if it's good, that's great. But sometimes they're a bit concerned because they can't taste the medication. And so I might say to them, well, if you're starting to get a bit unwell, pull out your little whistle. If you can't make a noise, that's a really good indicator to go and see someone because you're likely getting unwell, along with all the other things. So what do we do with this turbohaler? Well, we're holding it upright, okay? We're turning it one way and then back until it clicks. If your patient is deaf, can they hear the click? All right? These are things around encouraging adherence. Or are they going, you can check that at the same time, because they were told to take 2 puffs. They go like that. So turn back until it clicks. Then you're wanting an open airway as much as possible. So they're standing with their chin up slightly. They breathe out first. And then in as much as they can. And nice long sound from this. The reps tell me all the medication should be up within the first couple of seconds. But we like to hear a nice clear noise from that. The other thing about your turbohalers, I've seen these all mouldy, mostly because people have left them in a bathroom, or they've left them with a lid off in a bathroom, and the mould will grow in just a couple of days. So check that. People often don't realise that there is actually a counter on this. And in terms of encouraging adherence, I suggest to people that they put a mark on a calendar, that they put a note on their cell phone, when this is getting down, and they do it regularly. They can plan how many doses they're taking, unless they're on Symbicort Smart, of course. One of my first patients that I worked with when I started in the role that I'm in now was a young guy who was 15, and he had been into Middlemore 13 times in the previous 6 months or so. He had very, very poorly controlled asthma, and Symbicort Smart had just come out, and we talked about it as a department, and I thought, well, let's see if this is the right thing after talking with the docs. He came back into Middlemore with a silent chest, and I was sitting there in the emergency department, and I said, you've got to stop. If your aunt had gotten delayed at the traffic light, you would be dead by now. And I went to see him at home, and I got him to listen to his chest. Anyway, so I went to see him about 3 weeks later, and I saw he'd started using this. And I said to him, oh, really good to see you using this. And he said, yeah, I ran out of all my other medications and I was feeling really tight, so I thought I'd start using it. It's now been 7 years. He's come back into hospital twice, one for a broken hand, one for a broken foot. And on one of his, and the third presentation to emergency department in Auckland, and it's documented, a patient came in with an exacerbation of asthma requesting more Symbicort was told the wait was 5 hours, so he went to see his GP instead. And this is a young guy from a background that includes prison time, so very deprived background. So once they've got it, they've got it. Spiriva. Here's our spiriva. That's a Mark 1 version. Does anyone recognise that one? Remember when spiriva first came out? The difficulties patients had with getting this lip up. Do you remember that? And the company was really responsive. And this was the Mark 2 version they came out with really quickly. It's got the little lip on there. Now, one problem I've found with a HandyHaler recently, with some of my patients have just been telling me that the capsule's been crushed. And what we've worked out is that it's likely because the little spiky thing inside it is blunt after having had these for so many years. So it's worthwhile in your practice, and I'm starting to do this in my practice now, asking the patients, is there spiriva when they tip the little capsule into their hand? Has it got 2 neat little punctures, or has the capsule been crushed? I have a stack of these from an old research project, so I've just been dishing them out. But it's going to be getting to the thing soon. I have to tell them to go to the GP and get another sample pack to get another HandyHaler. Someone was charged $20 from a pharmacy the other day for a new HandyHaler. Almost finished. So we know how to use this. Capsule in there. Breathe out again. And you can breathe in several times, and that's one of the really cool things about this. If that capsule's not making that rattly noise, it could be that they've washed it and it's not dry in here. Just a tip for young players. Blast with a hairdryer or an air compressor or something is pretty good, or just in the hot water cupboard. Our breeze-halers. Has everybody seen these? I'll leave these out, by the way, so if anyone wants to come have a twiddle, they can. So this is our...
Just on this one here, there's current glossies going around from the company saying about the flow rate required for this inhaler is like 5 times the amount for spiriva. It's competitive.
Oh, okay.
So have you got any comment on that?
No, I hadn't heard that. What I have seen is, what I'm saying to our patients, is that that's, as with spiriva, you can take more than one breath. And because the capsule is clear, they can open that up and have a look and see if there's any more powder in it. They just take another next time they're taking it. So we haven't seen that as a problem because they can take more than one breath in. Is everybody familiar with the glycopyrronium and the indicatrol? These are the new, labas and lamas that's just come out. And there's going to be Ultibro. And
a
combination of these two.
2 or 3 years.
Yeah. So that's an interesting point. I'll have a chat to them when I get back to Middlemore. So this one, it's got a nice little on the side. Squeeze it in, puts holes in the capsule, breathe out. And the same thing, you can take multiple breaths in. This, you get a new device every month in each pack. So we're going to have heaps of these littering the environment soon. One more. Accuhators. I didn't realise until I did this talk how much more devices we've got now. Accuhators, lots of people like them. I asked the reps about inspiratory flow meters with this the other day, and they said, well, the disc is right here, and it's sort of all drawn up in the first 1 second. Load it, breathe out, and it's gone. And as I said, we don't have anything to measure except for our patient control, whether they've actually got that in. Of course, the other thing to add is always rinse your mouth out and spit out after you've taken your inhalers. And last but not least, we have something to make using a turbohaler a little bit better, easier to manage. And that's a little thing like that, fits on the bottom, free from your reps. You just turn it and then back. One of my patients has his blue tacked on the bench and he just does that way. Okay.